Hello, my name is Dr. Roy Fleischmann, Clinical Professor of Medicine at the University of Texas Southwestern Medical Center and co-director of the Metroplex Clinical Research Center in Dallas, Texas. I will be presenting highlights from the poster Long-Term Safety and Efficacy of 4-weekly Certolizumab Pegol Monotherapy and Combination Therapy in Rheumatoid Arthritis, 5-year results from an open-label extension study which I presented at the 2013 EULAR Congress in Madrid, Spain. Long-term safety and efficacy data can be important in helping to determine the safety of prolonged exposure to a medication over time and may provide information on the longevity of efficacy in patients who originally responded to a medication. The rationale for this study was to demonstrate the long-term effectiveness, by that I mean both safety and efficacy, of Certolizumab Pegol given each 4 weeks. Certolizumab Pegol administered every 4 weeks for the treatment of active rheumatoid arthritis was shown to have efficacy and an acceptable safety profile in 2 early studies when given either as monotherapy or with methotrexate. Patients from these 2 randomized, double-blind, placebo-controlled studies entered one open-label extension study. Results presented previously from the complete open-label extension study population of Certolizumab Pegol demonstrated that Certolizumab Pegol 400 milligrams every 4 weeks has an acceptable long-term safety profile. The objective of this communication was to evaluate the long-term safety and efficacy of Certolizumab Pegol monotherapy or in combination with the DMARDs given as 400 milligrams each 4 weeks over 5 years. Patients with active rheumatoid arthritis who were aged 18 to 75 years had active adult onset rheumatoid arthritis of greater than or equal to 6 months duration and had failed greater than 1 prior disease-modifying antirheumatic drug were studied in 2 clinical trials. One trial, referred to as Fast Forward, evaluated Certolizumab Pegol as monotherapy, 400 milligrams subcutaneously each 4 weeks in 220 patients, while the second study, referred to as 014, evaluated the same regimen in 247 patients who were methotrexate incomplete responders. In both studies, patients were treated with either Certolizumab Pegol or placebo for 24 weeks. Those patients who completed or withdrew on or after week 12 in either study were eligible to enter the open-label extension study of Certolizumab Pegol 400 milligrams every 4 weeks. Safety results were reported up to week 364, about 7 years, in this open-label extension study, the final data cut point for the last patient. The safety analysis population included all patients who received Certolizumab Pegol in the open-label extension study, including all patients completing or withdrawing early in either study, including those who were originally randomized to placebo and the double-blind phase who entered the open-label extension study. 467 patients entered the double-blind portion of both studies, 220 in Fast Forward and 247 in 014. 402 patients entered the open-label extension study, composed of 186 patients from Fast Forward and 216 from 014. Of these patients, 276 received Certolizumab Pegol 400 milligrams every 4 weeks in combination with at least 1 DMARD, and 126 received Certolizumab Pegol 400 milligrams every 4 weeks as monotherapy in Fast Forward. The efficacy analysis populations consisted of completers from both studies grouped into 3 subsets. The first, from 171 patients treated with Certolizumab Pegol who completed week 24 from the monotherapy and methotrexate incomplete responder studies treated with Certolizumab Pegol. The second, the 123 Certolizumab Pegol combination completers who had received either methotrexate or another DMARD at any point during the Fast Forward study, 014, or the open-label extension studies. And the third group were the 48 patients treated with Certolizumab Pegol monotherapy completers who did not receive methotrexate or another DMARD at any point during fast-forward 014 or the open-label extension. Efficacy outcomes were reported using observed values only for each time point. No imputation was used. No statistical comparisons were undertaken, as this was a post hoc analysis. Patients received 400 milligrams of Certolizumab Pegol subcutaneously every 4 weeks for the duration of the study. Visits were scheduled at the open-label entry, week 1, week 4, and then every 4 weeks thereafter. Treatment was continued until marketing approval in the respective countries was obtained, which was up to 7 years, and it was different in different countries. All patients were permitted to take DMARDs in the open-label extension, either from the study start or any time point, if they needed to take a DMARD in addition to Certolizumab Pegol. Observed patient retention and efficacy were reported up to week 280, 5.4 years, which was the last time point all sites were open, and safety up to week 364, which was the final data cut point, and that was 7 years, in the open-label extension. Patient demographics and disease characteristics were similar across all the groups at baseline. Over the course of the open-label extension, 6.4% of both fast-forward and 014 completers withdrew due to lack of efficacy or worsening of rheumatoid arthritis symptoms. In the 402 patients, the safety population, the most common reason for withdrawal from the open-label extension was due to an adverse event, 24.1% of all patients, followed by lack of efficacy in 7.5% of all patients. Retention at week 280 was similar between the Certolizumab Pegol Monotherapy and Certolizumab Pegol combination therapy, 50% in the monotherapy group and 55% in the combination group. The primary objective of this open-label extension study was to monitor long-term safety. The overall safety population was similar between all groups. The most frequent serious adverse events observed were infections or infestations, cardiac disorders, and neoplasms. The event rates per 100 patient years for serious infection, adverse events leading to withdrawal, and adverse events leading to death were similar between patients who received Certolizumab Pegol monotherapy and those that received Certolizumab Pegol combined with DMARDs. The pattern and frequency of adverse events in event rate per 100 patient years was any adverse event, 323 and 456, any serious adverse event, 16.5 and 27.5, serious infection, 4.2 and 4.5, serious malignancy, 0.8 and 1.9, adverse event leading to withdrawal, 6.3 and 6.8, and adverse events leading to death, 0.6 and 0.6, in the monotherapy and combination patients, respectively. 11 deaths were reported over the 7 years. 7 were cardiac, 2 were infectious, 1 was an injury, and there was 1 malignancy. Injection site reactions occurred in 1.4 and 0.9 patients and 0.9 in the monotherapy and combination patients, respectively. The overall event rates for some adverse events, such as injection site adverse events, infections, infestations, and serious adverse events, appeared to be lower in the monotherapy Certolizumab Pegol group compared to the Certolizumab Pegol combination group or all patients, but this could very well be a consequence of selection bias. It should be noted that no statistical tests were performed on the trends to lower rates of adverse events in the Certolizumab Pegol monotherapy patients compared to the combination therapy group or all patients due to the post hoc nature of the analysis and the fact that the combination and monotherapy groups are subsets of the all patients groups. The efficacy analysis population consisted of 171 patients who completed fast-forward and 014 and received Certolizumab Pegol during both studies and the open-label extension. Of all the Certolizumab Pegol fast-forward and 014 study completers, 123 received Certolizumab Pegol in combination with DMARDs, while the remaining 48 received Certolizumab Pegol monotherapy in both the double-blind and open-label studies with no other DMARDs at any point over the course of the study. At the open-label extension entry, the improvement in DOS-28-3 value, CRP, from both fast-forward and 014 baseline were similar for all patients, regardless of whether they received Certolizumab Pegol monotherapy or combination therapy. Comparable efficacy in all groups was maintained up to week 280. Similarly, improvement in health assessment questionnaire disease activity at open-label extension entry was also similar for all patients, regardless of whether they received Certolizumab Pegol mono or combination therapy. Furthermore, efficacy in all groups was maintained up to week 280. Patients who entered the open-label extension study had initial mean DOS-28-3 value CRP and change from initial study baseline of 3.9 and minus 1.9 in the monotherapy Certolizumab Pegol group and 4.1 and minus 1.8 in the Certolizumab Pegol combination completers at open-label extension study entry. At week 280, DOS-28-3 value CRP decreased to 2.9 in both the Certolizumab Pegol monotherapy and with a decrease of 3.1 and 3 in the Certolizumab Pegol monotherapy and the Certolizumab Pegol combination completers, respectively. So this showed that over time, there continued to be a significant improvement in the DOS-28-3 value CRP in patients who initially had a response to medication, did not have an adverse event, and continued in the study for a number of years. Mean HAC and change from baseline were 0.9 and minus 0.6 in the Certolizumab Pegol monotherapy, and 1.1 and minus 0.3 in the Certolizumab Pegol combination completers at open-label extension study entry, and 0.8 and minus 0.7 in the monotherapy Certolizumab Pegol monotherapy, and 0.86 and minus 0.5 in the Certolizumab Pegol monotherapy combination completers at week 280. So similar to DOS-28-3 value CRP, those patients who continued in the open-label study, who had a significant response and did not have a significant adverse event, continued to improve with respect to function as mentioned, as monitored by the change in the HAC. In conclusion, this open-label extension study has demonstrated that Certolizumab Pegol 400 milligrams every 4 weeks monotherapy has a favorable risk-benefit profile within this study population. Adverse events were comparable across treatment groups, regardless of whether patients received Certolizumab Pegol monotherapy or Certolizumab Pegol in combination with other DMARDs. Similar long-term improvements in disease activity and physical function were observed between patients who received Certolizumab Pegol monotherapy and those that received Certolizumab Pegol in combination with other DMARDs. And efficacy in all groups was maintained up to 5 years in patients continuing on therapy. Certolizumab Pegol monotherapy patients had a similar retention rate to the overall population, the majority of which were in combination therapy. Direct comparison was limited by the small numbers in the subpopulations. The implications of the analysis of the long-term open-label extension study is that certolizumab pegol is a reasonable choice in patients with active rheumatoid arthritis who have an incomplete response to methotrexate, and that certolizumab pegol can be used successfully in combination with methotrexate or as monotherapy, particularly in patients who cannot tolerate or will not take methotrexate. Over the long term, the safety and efficacy of certolizumab pegol monotherapy appears to be similar to certolizumab pegol in combination with DMARDs. One must understand, however, that these results are from a long-term extension study, and there are problems with long-term extension studies. They measure responses and safety in groups of patients. Only patients who respond well to medication in the blinded portion or respond well once they're given medication remain in a long-term extension study. Those who do not drop out, and therefore on a group level, one would expect to see an increase in efficacy over time because those who've dropped out for lack of response are no longer evaluated. That's particularly true in a trial such as this, in which only observed data is looked at. Similarly, with respect to safety, because the limited numbers of patients in a long-term extension, one would not expect to find rare safety signals. One would expect to find the usual signals that were seen in double-blind studies, but probably to a lesser extent, as only patients who do well with respect to adverse events continue in long-term extension studies. With these caveats in mind, however, it does appear as though certolizumab pegol monotherapy can be effective for a long period of time in groups of patients, as can certolizumab pegol in combination with methotrexate. With respect to frequently answered questions, the first question would be, presumably monotherapy patients from the feeder trials who chose to take an additional DMARD in the open-label extension did so because they were experiencing inadequate response to monotherapy. Doesn't that leave the monotherapy group with those most likely to respond and bias any comparison between monotherapy and combination patients in the open-label portion? The answer to this question is that any long-term extension study is biased, as only patients who respond well and have no significant adverse events remain in the long-term extension, as I previously said. However, with that being said, this database would seem to suggest there are at least some patients who respond to certolizumab pegol monotherapy long-term. Second question would be, were there any patient characteristics that could distinguish between those who withdrew from either the feeder studies, the fast forward or the 014, or the open label extension due to lack of efficacy from those who did not? The answer is that this was carefully evaluated, and there were no characteristics, either clinical, laboratory, just no characteristics that were found that would predict who or who would not respond. Third question is that since monotherapy and combination therapy patients experienced equal efficacy at the end of the feeder studies, fast forward and 014, that is, before monotherapy, placebo patients had the option of adding a DMARD, is there any circumstance in which adding a DMARD to certolizumab pegol is warranted? The answer is, we know from the phase 3 trials that there appears to be more patients who respond to certolizumab pegol in combination with methotrexate than those who respond to methotrexate monotherapy. The numbers were approximately 60% ACR20 response with combination methotrexate and high 40% with monotherapy. So I would use certolizumab pegol monotherapy in those patients, and only those patients, who are intolerant to methotrexate or who do not want to take methotrexate. I do think that it is a viable option in this subset of patients, and there is a fair chance that they will have a significant response without significant adverse events over time. The fourth question was there any evidence the development of anti-Certolizumab Pegol antibodies during the 7 years patients were followed? And the answer is antibodies do develop, but they are non-neutralizing, and therefore do not seem to have an effect on either efficacy or safety. Thank you for listening and watching, and I hope this information is of value to you, and it will be of value to you in your practice. Thank you.